Let's start again. Sorry, I had did not unmute. So, okay, timer's done. So, it is my absolute pleasure to introduce to you our hospital pharmacist, our New Brunswick Heart Center pharmacist, Krista Doiron. And you can read her bio, it's here, but you can also see her bio on our website. I just call her all that and a bag of chips because everybody knows my favorite is bag of chips, but she is our go-to person in our heart center. And public speaking, she looked at me when I asked her if she wanted to present, and she said, I will. She's a wealth of knowledge, and I am so honored to introduce to you Krista Doiron. And we're going to trade seats, and I'm going to move out of the way. Hi, everyone. Just going to take a minute to get my paper set up here. Pour myself some water. It feels weird to be at work without having a mask on right now. I promise I am 6 feet away from Sue, though. So thank you, Sue, very much for that wonderful introduction. So yeah, as Sue mentioned, my name is Krista, and I am the pharmacist here. I work up on the coronary care unit. And today I'll be presenting on the dyslipidemia guidelines. All right. So today I'll be presenting on the 2016 Canadian Cardiovascular Society guidelines. These guidelines were updated from 2012 with recommendations on statin-indicated conditions with an emphasis on risk assessment linked to lipid determination in order to help optimize decision-making and make recommendations for the use of non-statin medications. These guidelines are aimed to provide reasonable and practical approach to healthcare professionals in order to deliver optimal care to our patients. There are new guidelines that are set to be released at the end of this month. I will not be talking about those as they have not yet been released. So before we get into a lot of the guidelines, I thought we'd just do a quick little background here. So what is cholesterol? Well, cholesterol is a substance that is found in our bodies, and we need this in order to build healthy cells. There are two main molecules related to cholesterol. Each molecule can have a very different effect on cardiovascular health. One of the two that we'll talk about is low-density lipoprotein, otherwise known as LDL cholesterol. And that transports cholesterol within the bloodstream and deposits it into the walls of our arteries, creating plaque. And we've referred to this as bad cholesterol. The LDL is very important because it's directly linked to the development of plaque, and its reduction is directly linked to the reduction of cardiovascular disease events. The second molecule is high-density lipoproteins, otherwise known as HDL. And HDL actually removes cholesterol from our bloodstream and transports it to the liver. They minimize the creation of plaque and thereby reduce the risk of cardiovascular disease, which is why we refer to them as our good cholesterol. So dyslipidemia is abnormalities of lipids or lipoproteins in our blood. Dyslipidemia is generally defined as having an LDL of at least 3.5 millimoles per liter or greater. It's an important risk factor for cardiovascular disease. So dyslipidemia is directly linked to coronary plaque, which then leads to ischemic heart disease. And ischemic heart disease is the most common and significant consequence of dyslipidemia. So according to there we go, went the wrong way, sorry about that. So according to Stats Canada for 2012 to 2013, there's about 2.4 million Canadians aged 19 or over who are living with ischemic heart disease. Heart disease is also the second leading cause of death in Canada, claiming more than 48,000 lives in just 2012. So who are we screening for dyslipidemia? So the CCS recommends that we screen both men and women older than 40 years of age. They also recommend that you screen them at any age if they have any conditions such as clinical evidence of plaque, diabetes, current smoker, a family history of premature cardiovascular disease or chronic kidney disease, and that's just a few to name. So what they define as a family history of premature history of premature cardiovascular disease as if an event in a man less than 55 and women less than 65 if it's a first degree relative. Chronic kidney disease is also defined as having a creatinine clearance of less than 60 mils per minute for at least a 3-month duration. So now we know who we're screening. How are we screening these individuals? Well, one of the biggest changes in 2016 compared to 2012 was the recommendation that non-fasting lipid testing is actually acceptable. This recommendation comes from the data from the National Health and Nutrition Survey, demonstrating that the ability to predict cardiovascular disease outcomes was identical for both non-fasting and fasting LDL determination. So non-fasting doesn't affect the risk assessment strategies because the total cholesterol and the HDL cholesterol did not vary after eating. And that's important because the total cholesterol and the HDL cholesterol are what we used in the formula for the Framingham risk assessment. So all that being said, you don't need to fast anymore to check the LDL unless the patients have a history with triglycerides greater than 4.5. If they are greater than 4.5, they recommend that you still do a fasting lipid screen. And that's because those individuals were actually not included in the studies, so they can't make a recommendation on that subgroup of lipid panels. And obviously fasting, the non-fasting state is a lot more easier for the patients as well. So how do we screen? I think I missed this slide. Yeah. So one of the things that they're also doing would be to do a history and a physical exam, which would be performed, and a standard lipid profile consisting of total cholesterol, LDL, HDL, and triglycerides in order to have them tested. In addition, they recommend doing a glucose and a creatinine clearance in order to determine how their kidney function is doing. So we're going to talk about some statin indicated conditions. So the risk assessments are not required for individuals if they have statin indicated conditions. And that's because this group is considered to be high risk. So this group actually achieves the greatest absolute benefit from lipid lowering agents because they're at high risk. There are 5 conditions. There's clinical plaques or previous MI, PCI or CABG, angina pectoris, cerebral vascular disease, including TIAs, abdominal aortic aneurysms, if they're diabetic, which they define as being 40 years of age or older and having diabetes, or more than a 15-year duration of diabetes and you're at least 30 years of age or older, or if you have microvascular disease. They also have chronic kidney disease, which I had told you earlier just in the previous slides that they describe as having a creatinine clearance of less than 60 mils. And they also, the other last group of statin indicated conditions is if you have an LDL of 5 or greater. So with this group of individuals, there's been no recommendation made on the dose or anything like that of what type of for the statin to put them on. However, they do recommend to have a 50% reduction. And in order to achieve a 50% reduction, you would probably put them on a moderate to a high dose of a statin in order to achieve that. So primary prevention conditions. So the Framingham risk score is used to estimate the 10-year risk of manifesting a clinical coronary artery disease. And the Framingham risk score is based is used, and it calculates your age, your sex, your smoking status, your blood pressure, your total cholesterol, and your HDL. And there's 3 categories. There's the low risk individuals, the intermediate risk individuals, and the high risk individuals. And we're going to go through each one of those categories. So the low risk category applies to individuals who have a modified Framingham risk score of less than 10%. So most of these individuals don't require any pharmacotherapy. We just monitor them. If they have a Framingham risk score of 5 to 9%, we'll do it every year just to make sure that there has been no change in their status. The intermediate group are the ones who have a modified Framingham risk score of 10 to 19%. And this is probably where a lot of people fall into this category of the intermediate risk. You're not quite sure which way these individuals are going to go. Are they going to slip into the high risk group, or are they going to stay where they're at? You know, they're kind of the ones that we focus a lot of our attention on. So statin therapy is kind of added to these individuals in addition to behavior modifications. It's a little bit more appealing for these individuals. So they're kind of a little bit in that zone. So we'll suggest some behavior modifications. If it doesn't work, then we may have to consider going down the road of statin therapy. And treatment gets based on inclusion criteria for primary prevention, such as if an individual has an LDL of cholesterol of at least 3.5 or greater. They also make recommendations that patients be considered to be started on a statin if the LDL is less than 3.5, but if the non-HDL is actually greater than or equal to 4.3, or if they're a man who is at least 50 years of age and a woman who is at least 60 years of age or older, and if they have one additional cardiovascular risk factor, such as the low HDL cholesterol, impaired fasting glucose, an increase in their waist circumference, if they're a smoker, or if they have hypertension. And then the high risk group, so these individuals have a Framingham risk score of at least 20% or greater. It's the least common group until individuals hit the age of 65, and then they kind of slip into this age group. And that's probably because when we get older, we get a lot more hypertension and things that come along with it. So a statin would be indicated for these individuals as well because they are high risk. So now that I've just gone through all of that, we're just going to take a little time and go through a little case and kind of put it all into perspective here. So this is LB. LB is a 55-year-old Caucasian female who weighs 90 kilos. She has a height of 170 centimeters. Her past medical history is significant for atopic dermatitis and seasonal allergies. Her home medications are cetirizine 10 milligrams PO daily. A social history, so she smokes 1 pack per day, she has 1 glass of wine per day, and she exercises about 3 times a week. Her blood pressure is 120/80, and she has a heart rate of 70. She has a lipid panel done that comes back with a total cholesterol of 6.3, an HDL of 0.9, and an LDL of 3.8, and triglycerides of 2.1. So what is LB's medical problem? What is her modified Framingham risk score? And does she require pharmacotherapy? So this is kind of a screenshot of what it looks like when you're doing the Framingham risk score. So you can see that it gets broken. This is for women's because LB is a female. The older you get, the more risk points you get as well. If you're a smoker, you get more risk points. If you're diabetic, you have more risk points. And then your total cholesterol, you get more points the higher your total cholesterol is. Your blood pressure, not only do you get more points with the higher blood pressure, but you also get more points if you're actually being treated for your blood pressure. And then you get less points with the lower the LDL is. So for LB, she had a total risk points of 16, which translates to about a 16% 10-year risk. So what is her current medical problem? Well, she has dyslipidemia. And her modified Framingham risk score, so because she's 16%, she falls right into that intermediate range. So does she require pharmacotherapy? Yes, a statin. And that's because her LDL was 3.8, and it recommends to start a statin when your LDL is greater than 3.5. So what will the targets be for LB? That's usually the second question that we get asked a lot as well. So this is a little table here, kind of breaking down what we just went through, the primary prevention in our statin indicated conditions, what is the definitions, and what the targets are. For the most part, the targets are going to be a 50% reduction or an LDL less than 2, which we call a treat to target approach. So the only thing that differs from that is that for the statin indicated conditions, you'll see down at the bottom, is that if the LDL is actually greater than 5, we actually just would like it to be at least a 50% reduction in the LDL. And that's just because we want to get kind of the most bang for our buck, if you will. And then I also just wanted to point out that for every millimole per liter reduction in our LDL that we get actually translates to be about a 20 to a 22% risk reduction. So it's really beneficial in getting these patients on statins. So bringing it back to LB, so like I said, intermediate risk, LDL of 3.8, so her target would be an LDL less than 2 or a 50% reduction. So now we're going to go through some therapeutic management. So the goals of therapeutic management would be, we want to reduce mortality. We want to prevent complications and morbidity, such as non-fatal MI, non-fatal stroke, peripheral vascular disease, chronic heart disease. We also want to prevent pancreatitis, which can occur when patients have really high triglycerides. We want to have resolve any signs or symptoms for these individuals, and we want to prevent medication adverse events and reduce and eliminate any modifiable risk factors if we can. So looking at non-pharm choices, so diet is aimed at reducing blood lipids and weight if needed, and it should always be part of the treatment. Smoking, quitting smoking is probably the single most important health behavior intervention for the prevention of cardiovascular disease. As we know, smoking has adverse effects on our lipids. So there's actually a linear and dose-dependent association between the number of cigarettes smoked per day and the risk of cardiovascular disease. Individuals might choose a dietary pattern alone or as an add-on to their lipid therapy in order to achieve their targets. If they do, the diets we recommend are the Mediterranean, Portfolio, or DASH dietary pattern. It's also recommended that adults should accumulate at least 150 minutes of moderate to vigorous intensity aerobic physical activity per week and intervals of at least 10 minutes in order to reduce the cardiovascular risk. Other lifestyle changes are also important to modify the lipoprotein profile, such as maintaining a healthy body weight, drinking alcohol in moderation, getting sleep at least 6 to 8 hours at night, and helping to keep stress at bay. So pharmacological options, my favorite. So this table summarizes the effect of lipid-lowering drugs on lipoproteins. So statins are recommended as first-line lipid-lowering agents. Other agents that you see listed here are from different classes that can be substituted if the statins are not tolerated or added if the lipid targets are not being achieved. So you can see here, this is important because it helps us kind of decide which one we are going to use as an add-on if needed. So of this category for LDL, you can see that statins and the PCSK9 inhibitors are very good at lowering the LDL. Whereas HDL, niacin, and fibrates are actually really good at increasing the HDL as well as lowering the triglycerides. So statins. So statins are the first-line therapy for patients requiring medical management of dyslipidemia. We always recommend that you start at low doses and kind of titrate upwards while monitoring the markers, which we'll talk about shortly. The liver function should be checked at least once every 3 months. And common adverse reactions of statins are increase in CKs and LFTs. These should be performed at baseline and then again at 6 weeks to at least 3 months. There's no need for routine LFTs after, or the CKs for that matter, after we check them again. It's a kind of expected or kind of, assumed that you can have asymptomatic increase in your LFTs that can occur actually up to 3 times the upper limit of normal. This is usually generally self-limiting. It appears to be more of a dose dependent, and it's usually reversible if you need to when you stop the statin. Other reactions are GI disturbances, so patients can get dyspepsia that can occur, and it usually resolves after about 2 to 3 weeks. Myalgias, that can occur with or without CK elevation in about less than 1% of patients. What we do is we educate our patients to report any dull aches to any of their large muscles that they can't explain by like working out or any sort of activity. We'll get them to kind of report it and we'll check their CK and then we'll kind of manage them from there. So statin-induced myopathy, I'm sure everybody has heard this a lot. It's one of the biggest concerns we see or hear here at the Heart Center when we talk about patients and putting them on statins. So this is kind of a nice little algorithm that kind of walks you through how you could manage a patient with it. So you have a patient who has muscle-related symptoms, you do a history, you do a physical examination, and you'll check their CK. If the CK is normal, it's probably myalgia. So you would just consider the risk versus the benefits of the statin. You can continue the statin, you can reduce the statin or stop it, or you can consider an alternative agent altogether. If the creatine kinase is less than 10 times the upper limit of normal, you would stop the statin. You'd monitor the CK until it comes back down into the normal range, and you would consider predisposing factors, treat those if possible. It says that you can consider repeating the statin with the same one, but at a lower dose, or you can just choose an alternative statin. From my experience, we don't typically start the same statin. We would just switch them to a different one. If the creatine kinase is greater than 10, then we would stop the statin, we'd check renal function and a urine myoglobulin, and it's probably more likely rhabdomyolysis, so we would treat that if required. And then we kind of just do the same sort of thing. We'd monitor the CK until it's back down into the normal range, consider the predisposing factors that could have led to the patient for rhabdomyolysis. And this one here, we would probably not do a statin again. I think it would probably take a lot of convincing to get the patient to even consider that. We would probably just consider doing a non-statin medication at this point. So statins, some other kind of like theories out there with the concerns of statins is that there's this concern that there's risk with new onset diabetes and some anecdotal reports of memory loss. So although the potential increased risk of diabetes does appear to be related to high doses of statins, there's currently no recommendations against the use of high dose statins. There has been a link between the use of statins and dementia, being that it's probably unlikely, and any potential protective effect is still remains undetermined at this point in time. And then just some kind of little things to kind of keep in mind from the statin class is that rosuvastatin and simvastatin are the two that are going to increase your HDL the most out of all the statins. Atorvastatin and rosuvastatin are the two that are going to decrease your triglycerides the most. Atorvastatin, lovastatin, and simvastatin are the ones that you need to be careful with when patients are on other CYP3A4 inhibitors. So amiodarone, colchicine, grapefruit juice, those are the ones that we have to kind of talk to the patients about and we need to be a little bit more careful with. Antacids should be administered 2 hours after taking rosuvastatin, and that's because the antacids can actually decrease the serum concentration of rosuvastatin. The mechanism of this interaction is unknown, but the theory behind it is that the salt that's in rosuvastatin is actually a calcium, so they think that the antacid binds to rosuvastatin and stops it from being absorbed into the blood. And pravastatin is not metabolized through this P450 pathway, so that's one to consider when you have a patient who is on a lot of medications that you would like to put them on statin. For example, it was just this week, we had a patient, they were actually a heart transplant patient, so they were taking some anti-rejection medications like cyclosporine, Cellcept. So obviously you can't take atorvastatin with those, so we actually did put them on pravastatin, and we'll just monitor their LFTs and everything a lot more closely. So cholesterol absorption inhibitors such as ezetimibe, or Ezetrol is the brand name. So these are first-line statin add-ons for patients, especially those who have clinical cardiovascular disease and chronic kidney disease who are not at target with maximum tolerated statin doses. They can also be used in second-line patients who are not able to tolerate statins where the statins are contraindicated. So why do we use Ezetrol? Why is it the second line, if you will? Well, there was two studies that I'll just very quickly tell you about. One of them is the study of heart and renal protection, otherwise known as the SHARP study, which was in the Lancet 2011. And they looked at about 9,000 patients who were between the ages of 40 to 80 who had chronic kidney disease and no known cardiovascular disease. They compared simvastatin 20 milligrams daily with ezetimibe 10 milligrams daily to placebo. And what that study showed was that the combination of simvastatin and ezetimibe significantly and safely reduced the risk of plaque and vascular events compared with just placebo. So that's why that's kind of a consideration of patients who have chronic kidney disease. The other study that we'll talk about is called the Improve It study, which was in the New England Journal of Medicine in 2015. And they looked at about 18,000 patients who had a recent acute coronary syndrome. And they compared simvastatin 40 milligrams daily to simvastatin 40 milligrams daily plus ezetimibe 10 milligrams daily. The LDL was decreased to less than 2 in this study. And this study showed that simvastatin with ezetimibe also reduce the risk of major coronary events such as non-fatal stroke and death from cardiovascular causes. And that's why this one is considered as an alternative regimen if the more potent statins are not tolerated. So our bile acid sequestrants, honestly, I haven't seen a lot of these used in a very long time, but you know, you might be seeing them used in like a community or having a patient come on, be admitted who are on these. So these ones here, their place in therapy would be also as an alternative, but they're an alternative to ezetimibe as the first-line statin add-on therapy. They can be considered as monotherapy in patients where statin is not tolerated or contraindicated. And that's because of colostramine, the first one up there. And there was actually a study called the Lipid Research Clinic's Coronary Primary Prevention Trial. And this study actually predated statins, okay? So this was in 1984, the year I was born. So this one here, what that one actually looked at is that they looked at cholestyramine 24 grams per day, and they compared it to placebo. And what they found is that cholestyramine was shown to significantly reduce cardiovascular events. And it was more, when they looked at the inclusion criteria, it was actually more asymptomatic middle-aged men who had primary high cholesterol. So it is there to use as a monotherapy if for some reason the patient couldn't take a statin and couldn't take ezetimibe, you know, that would be something to consider as well. The other one, nicotinic acid or niacin, to be honest, I've never seen these being used. I learned about it in pharmacy school, but I haven't seen them used in my practice. But these ones, so niacin actually helps the HDL in your triglycerides, but only at the higher doses does it actually affect the LDL. And when we get into these high doses that we want, in order to dose reduce the LDL, we actually get into some very unpleasant side effects. The biggest one that comes with niacin is actually flushing. So it really limits the use of these because of the adverse effects. And the only other thing I wanted to say with this is that, you would consider this in patients who don't achieve appropriate LDL targets, but you would never combine niacin with the statin therapy for cardiovascular disease prevention in patients who have already achieved their targets. Fibrates. So fibrates lower triglycerides and raise our HDL. The effect on LDL is kind of variable. The two that have been shown more consistently to lower LDL has been bisfibrate and fenofibrate. There is a possible benefit in high-risk patients with residual high triglyceride levels and low HDL. I can think of a handful of times where we've had to actually put a patient on both. The patient still had high triglycerides, so they actually dose reduced the statin and added the fenofibrate and monitored the LFTs a lot more closely, and told the patient if any signs or symptoms of any muscle pain to just stop it immediately. You don't combine fibrates with statin therapy for cardiovascular disease prevention in patients who have already got target. The biggest concern with fibrates, in addition to statins, is the risk of rhabdomyolysis. They're both known to cause rhabdomyolysis, so you get an increased effect with that. Okay, so the new kids on the block. The pro-protein convertase substitution type 9 inhibitors, which I will now say is PCSK9 from now on. So these ones are new within the last couple of years. We're going to go through a little bit of them, but before I get too far into it, I just thought I would just kind of explain, like, what is a PCSK9 and like what is the inhibitors doing. So I have a little cartoon here up on the screen, and if you look at figure A, I'm just going to kind of explain that one first. So LDL, which is in the bloodstream, binds to the surface of the cell on the LDL receptor. They get internalized. Once inside, the LDL gets released to be broken down, and the receptor travels back up to the surface of the cell in order to bind more LDL. At the same time that this is occurring, PCSK9, which is a protein that naturally occurs to help control the LDL receptors, gets released into the bloodstream. The PCSK9 binds to the LDL receptor, and then they bind to the LDL. So the LDL, the PCSK9, and the LDL receptor all get degraded once inside the cell. So what that means is that you have less LDL expression, which allows more LDL into the bloodstream. So by taking an inhibitor, the PCSK9 inhibitor, as you would have guessed, binds to the PCSK9. So the LDL and the receptor go inside, and then the cycle can continue on that way. So because it allows more LDL expression, you actually have more LDL clearance from your bloodstream. So there's two PCSK9 inhibitors that we have right now, and these, like I said, are monoclonal antibodies to PCSK9. So they result in substantial LDL cholesterol reduction. So currently, right now, currently by 2016, they're first-line statin add-on options for patients who have FH, which is an LDL of 5 millimoles or greater. They're also second-line add-on for patients with other statin-indicated conditions that we talked about earlier. It's recommended to consider using PCSK9 to lower cholesterol levels for patients who have cardiovascular disease, who you can't get at target despite being on maximally tolerated statin doses with or without ezetimibe therapy. The biggest limit to using PCSK9 inhibitors are their cost. They're extremely expensive, so they're limited to the high-risk individuals. So the two that we have, all right, I'm going to try and pronounce these words, alirocumab. So the dose, or Praluent is the brand name. So they're 75 to 150 milligrams administered subcutaneously once every 2 weeks. They cost about $589 a month. So it's quite expensive. The other one is evolocumab, and that one is 140 milligrams subcutaneously. And this one you can do either every 2 weeks, or you can do 420 milligrams once monthly. And they cost anywhere between $534 to $786 a month. So they add up, yeah. So some therapeutic tips that I thought I would just leave you guys with would be that the cardiovascular management initially involves modification of health behaviors in addition to lipid-lowering medication. Lipid-lowering drugs should not be a substitution for diet therapy. It should always be an adjunct to. You know, we usually try different agents within the same class before we would consider saying, no, they can't take this statin, and we'll move on to a non-statin therapy. We'll allow 3 months for a stabilized representative plasma lipid profile, and doubling the dose of a statin will further reduce the LDL level by about 6%, but it kind of doubles the risk of the adverse events from occurring. And thank you guys very much. I'd be happy to take any questions.
Awesome. Thank you. Thank you very much.
No problem.
So I am going to hit